So I find it's very institution dependent. There seems to be institutions that are believers in the neoadjuvant approach, even in a resectable patient versus not. How do you do it at your institution?
Yeah, I can tell you that in patients who have resectable disease, the standard of care continues to be surgery upfront. And in institutions that have been doing it, and they've done it for a long time, like MD Anderson, I haven't seen any major conclusions from it. Unfortunately, this continued to be institution dependent. Every institution, if they wish, they did their own study. At this time, there is a national trial, which is led by Dr. Soval from a Cleveland Clinic, and SWOG is involved with it. It's a study of combination chemotherapy prior to doing surgery. Now, that treatment, which is given prior to surgery, is a comparison between nab-paclitaxel gem and FOLFIRINOX. It's not so much a comparison. You're trying to get pick the winner so that the next generation of trials using neoadjuvant treatment will be done. But the point to make is that it's not a standard of care. Now we're moving into it. Now, what about radiation treatment? That trial does not include radiation therapy up front. The reason for that is we're making a bit of a distinction between resectable disease, where the surgeon is almost confident they can go in and do an R0 resection, versus borderline resectable. Remember, borderline resectable is still resectable. What the surgeon is saying, I can resect it, but I'm just a bit concerned I'm going to leave a positive margin. So in the borderline resectable disease, the clinical trial which is now being developed will include radiotherapy, because so that's one point. The second point is that in borderline resectable disease, or even resectable disease, a measurement of response is not really that important, because even if you don't see a response, it may affect the margins. So the thing is that we need clear margins, as clear as possible. So the measurement of response isn't that much of importance, and we don't maybe care as much about it at this point in time. Now, my dream is that in resectable and borderline resectable disease, we end up doing something like we do, for example, in esophageal cancer. We give all the treatment up front, chemotherapy systemic. Mm-hmm. We may do the radiation treatment, and then we go to surgery. Mm-hmm. Some patients may not benefit from surgery, we know that. But also that wait of 4 to 6 months, which now our surgeons are less concerned about, might also tell us the biology of the disease. If someone develops liver metastasis during that time, then you know your surgery won't make sense, or radiation treatment. So the paradigm shift may come, bringing systemic treatment earlier. Mm-hmm. Why is it important? Because from our experience, even in patients who have resectable disease and they look fine, giving even single agent gemcitabine after surgery can be a struggle in some patients, in a lot of patients. In fact, only 40% or less than 50% really get good going systemic therapy after surgery. So how are you going to give combination chemotherapy? So if you do it before surgery in this disease, where nutrition is a problem, complicated surgery is a problem, it makes more sense. So I think that's where the future is moving. Yeah. But still, standard of care is surgery for resectable disease and neoadjuvant chemotherapy and chemoradiotherapy for the borderline resectable disease.
So certainly, Tom, it's all over the place, right?
Yep.
You get people using the new chemotherapy regimens. You had some MD Anderson data that came out at ASCO last year using FOLFIRINOX plus chemoradiation therapy for surgery. You know, what's grand old Farber doing now?
So I think for borderline resectable disease, which in and of itself is not the easiest thing to pin down, we are typically using FOLFIRINOX based on the fact that the response rates in the metastatic setting are higher than gemcitabine nab-paclitaxel. Not tremendously higher, but I think enough to make it a more attractive regimen. Mm-hmm. And then, you know, hoping for the best. And Dr. Phillip was I think, presented a very a cogent discussion of sort of what we're thinking. I think ultimately giving the treatment up front, the benefits are you might be able to assess a response. Mm-hmm. You're going to have a period of time where you can observe the biology of the disease, which I think is critical. And if ultimately you can't operate, mm-hmm. well, then you were giving effective therapy for metastatic disease anyway.
Right.
So I think the potential role for neoadjuvant therapy is, it's not potential. I mean, we're using it, and we're using it often. I think it's not a standard of care for absolutely resectable disease, but it's not inconceivable that it will become one, just because of the poor, the rates of recurrence are so high. I think most people believe that gemcitabine adjuvantly is weak therapy, maybe not very helpful, maybe delaying recurrences but not really curing patients. So trying to give more aggressive therapy up front hopefully will lead to more cures, and these trials are underway. So I think we're bound to get data at least sometime in the next few years.
So for your borderline resectable patients, your locally advanced patients, in your own hands, just anecdotally, are you converting more people?
So maybe.
Yeah.
I'd say it's more. It is really hard to tell what kind of response a patient has gotten from CT scans and MRIs. And I think that ultimately, if your plan was to take a patient to the OR and there hasn't been any substantial change, I think it should still be the plan to do so, and then really make the decision intraoperatively, because there are certainly anecdotes of patients who were felt not to have been downstaged and then were taken to the operating room and ultimately were found to have very good responses and were able to be operated on. Whether they were, whether it was resulted in long-term disease-free survival or not, I don't think we know. But I think the very fact that patients were able to be taken to the operating room when their radiology was still very ambiguous speaks to the fact that this is at least effective at downstaging.